colleagues to show the PowerPoint. Actually, all the work has been done by Dr. Srija, my colleague here, and I am just walking in.
Yeah. So this is 29 years male with primary diagnosis of tricuspid atresia with VSD with PS and normally related great arteries. Has undergone bidirectional Glenn shunt in 2010 and antegrade flow was left alone. Has undergone fenestrated Fontan surgery in 2014. Presently he has a class 2 effort intolerance and currently on tablet warfarin. He on examination his saturation is 86% with weight of 63 kg, BP is 110 by 60, pulse rate is 60 per minute, first heart sound is normal, there is single second heart sound, and grade 3 by 6 ejection systolic murmur in left sternum border. ECG shows sinus rhythm with PR interval of 120 milliseconds. Left axis deviation QRS axis is -60, prominent LV forces. X-ray shows situs solutus levocardia CTR of 50%, sternal bias seen, normal lung feeds. Echo shows tricuspid atresia with mild ventricular dysfunction. On the right side we can see the Fontan fenestration which is shunting from conduit to the atrium. So this is the pulse Doppler in the Glenn circuit which is showing pulsatile flow in the Glenn. So echo is tricuspid atresia VSD PS, antegrade pulmonary blood flows are present, fenestrated Fontan circuit with fenestration flowing from conduit to the RA with mild LV systolic dysfunction. So we have done a cath for this patient. So from mixed venous saturation of 69%, there was a step up into the PA with 83%, and on the left side pulmonary venous saturation were 97%, which stepped down to 91% at the aorta level. RA mean pressures were 9, RV pressures were 85 with EDP of 12, PA pressures were mean of 13, pulmonary venous which mean pressures were 5, and left sided LV pressures were 110 with EDP of 12, aortic pressures were 120 by 65. QP was 5.5 liters per minute with QS of 3.5 liter per minute. Right to left shunt across Fontan fenestration we calculated 0.7 liters per minute and QPQS of 1.57 QPQS of 1.57. PVRI was 2.42 with SVRI of 40.48, PVR SVR ratio of 0.06. So this is the injection into the Glenn shunt which is showing well functioning Glenn shunt and good flow into the both the branch phase. This is the injection into the Fontan pathway which is showing shunting across the Fontan fenestration into the atrium. And this is the catheter pass from Fontan into the PAs and antegradely across the pulmonary wall into the RV which is showing hypoplastic RV, dilated pulmonary annulus and antegrade flow across the pulmonary wall. So a plan for today is closure of antegrade pulmonary blood flow and closure of Fontan fenestration after balloon occlusion test.
What is the clinical status of this patient?
Around 85% saturation, little bit of cyanosis, and whenever he exercises it drops down to 75%. He is on warfarin and nothing else.
So it's an exercise-induced desaturation.
I mean even resting desaturation.
Doesn't have any pleural effusion?
No, sir. No pleural effusions.
He doesn't have any pleural effusion.
He doesn't have a pleural effusion. He is not needing any diuretics.
The indication for the procedure is the desaturation.
Exactly.
Antegrade flow.
And a persistent antegrade flow, which in the long run is going to be hurting the Fontan circulation.
Loose.
What is the PA pressure, Shiva?
PA pressure is 20 today. On the day of the diagnostic cardiac catheterization, we were getting between 13 to 15, but today it is 20 millimeters of mercury. And I'll show you where we are. Like go to the first picture. So you go to the first picture. Okay. So basically, what we have done is we have two catheters on the venous circuit.
Shiva.
Yep.
Shiva.
Yes, Bharat.
Shiva, we want to go to China for exactly 1 minute for them to show us the post-dilatation hemodynamics and maybe aortic root angio, and we come back to you.
Sure.
I'm so sorry, but we'll just take 2 minutes, go back to China and come back.
Sure.
Okay?
Okay.
Continue with what you're doing though. Shiva, we are back with you.
Okay.
And
so
Dr. Suresh has a question.
Yeah, please.
Shiva, your plan
Yeah.
was to do the fenestration closure and also the
stop the antegrade flow.
First the antegrade flow.
So I have a,
First only the antegrade flow.
there.
First only the antegrade flow. About the fenestration.
Shiva, 1 second. Shiva, the question, he's 28 years old. This is the time
10
when many
millimeter
Fontans
balloon ready
actually
ஆயிருக்கா?
require a fenestration because they are getting into trouble. Your patient is doing well. He has an aortic saturation of 90% and he has some antegrade flow. So is there a case for stopping that antegrade flow, deferring the fenestration closure and see how the patient does?
Can I explain? Fontan antegrade flows are going to increase the Fontan pressures. The Fontan pressures are going to make the desaturated blood that is returning back from the inferior vena cava through the conduit to again enter into the atria. The antegrade flow is actually a saturated blood that is entering into the pulmonary artery, ineffective left-right shunt. And the Fontan fenestration, which is right-to-left shunting,
I
caused
have no
by
question regarding the antegrade flow, Shiva.
antegrade flow is worsening the
No,
Fontan
asking about
fenestrations right to left.
Regarding the
We'll only
antegrade flow.
balloon occlude and
Yeah,
see.
we are not deciding to close the Fontan fenestration. The primary reason now is we are going to close first the antegrade flow,
Oh, okay.
and then we will check the pressures. We will do a balloon occlusion. That is going to be another few minutes later. So first let us close the antegrade flow.
Oh, excellent. Fine.
Okay.
That's fine.
So
Go
now
ahead, Shiva, go ahead.
Okay,
I think
now
Dr.
we-
Suresh misunderstood you.
okay. Now this is the main pulmonary. This is the right ventricular outflow tract angiography in LAO cranial projection, where you can see the tight infundibular narrowing and then very roomy main pulmonary artery, and then there is a banded segment. Actually, the banded segment, the surgeon felt that he is interrupting the PA by putting a tight ligature around. However, it has resulted in persistent antegrade flows. Next picture. So what we have done now is, we have now taken an ICE catheter and we have entered very close to that antegrade pulmonary blood flow, and we are viewing that area with ICE, and we are going to now take, we are going to close that narrowed banded site. We are going to use a new device, show big here. This is a LifeTex multifunction occluder. It's named as multifunction occluder because it has been used for closing coronary artery fistulas, AP collaterals, Fontan fenestrations. Any sort of condition that you want to close, it can be closed. This is extremely low in its profile. The thickness of this is comparable to ADO2. It has got 2 screw ends, so you can screw in from either the proximal end or the distal end. The device has got a shape which is, here it will look like an ADO1 device. I'll show you. Here it will look like an ADO1 device, and here this is a waist. This is another second body. This is a non-self-centering device. You can appreciate there is a central fabric to accelerate the thrombus formation. It's very low in its profile. This is a large 14-12 multifunction occluder, which is the largest multifunction occluder. It has got a surface of 18 millimeter on both the sides, and it goes through just a 7 French sheath. If I go for a smaller size like 8-6 or 9-7 or 10-8, I will be able to go even through a 6 French sheath. The larger ones have fabric, the smaller ones do not have fabric. So this particular device we are going to use to close the antegrade flow, and now since we are going sort of retrograde in the pathway because we are entering from the main pulmonary artery, right pulmonary artery into the main pulmonary artery. I am loading the device in such a way that the bulkier portion is actually facing the antegrade flow, and this is going to be my retention skirt. So we can load it either way. If I am going from the ventricle and going to close it, I can load it the other way. So right now we are show ICE live, show echo 50%.
Shiva?
Yes.
It's Elchanan. Please keep on working. I just want to ask you something.
Yeah.
All of us have these patients that have a pulmonary valve and have a distal band, or the surgeons try to close off the antegrade flow. The problem is that when you close with the device at the level of the band, you're creating a pouch between the pulmonary valve tissue and the device. And that's been described as a place of stasis, which can cause thrombosis, and then the patient can create large clots, which then will fall into the ventricle and can embolize.
Yeah.
So is it the right approach to close at the band and leave the valve leaflets there?
Actually, this same doubts we had in the past. However, there were quite a significant number of occasions where we were forced to do this particular step in our clinical practice in all these years. And contrary to our expectation that the proximal thrombus is going to progressively migrate through the entire hypoplastic right ventricle and then pass through that restrictive ventricular septal defect and enter into the left ventricle, these patients actually remain quite stable. In fact, we probably have closed about 10 to 11 patients with such antegrade flows, and none of them had any problem. In another point to note is, it is our customary practice in India to give all extracardiac conduit Fontan patients warfarin at a dose to maintain the INR between 2 to 2.5. So maybe because of that, we don't get to see a thrombus that is migrating. But however, in many countries, it's a routine practice to give only aspirin, and maybe in those countries we need to be worried about it.
So Shiva, you would suggest that if you are doing this sort of mandatorily, you will keep them on warfarin. Your point was anyway you are going to keep them on warfarin.
Always, all our patients of Fontans are on warfarin, with the exception of patients who have had serious bleeding complications on warfarin. Otherwise, all of them will be on warfarin. Give me an ADO2 cable.
Tell me about the size of the device and the banding area. How did you choose this device size based upon the band area?
The banded area, we were not able to measure it at all, Zahir. Now the thing is, this is the largest device and it has got a waist.
Oh, okay.
I assume that when the surgeon told me he is actually completely ligating it off and he is obliterating the flow, but he has ultimately it has resulted in a residual flow. So I feel that it is going to be very small. So I would anticipate something between 4 to 5 millimeters, and definitely this 18 French is going to be working reasonably well. I'll tell you one of the technical problems that I had now. This is a 3 French cable that I tried to use. However, this cable pushability was quite low. So I am now changing over to a 5 French cable, again from the LifeTech, and no, ADO, 5 French LifeTech cable. Quick. So that the pushability of this 3 French was quite low.
Shiva, was cable the problem or the loading sheath was the problem?
The loading sheath is a 7 French sheath and we have taken an 8 French flexor. So normally we load in a 7 and go through a 8 French sheath and it normally works.
It should not be a problem.
Yeah, but now I am taking a LifeTech 5 French cable, which probably will have a little bit better pushability. Pull it.
Shiva, Dr. Sahid's question.
Yes.
That you chose the largest available device in this, no?
Correct.
With a 4 millimeter thing. What was the calculation? So, for instance, why not a 10-8?
Because the main pulmonary artery is so roomy, the proximal pulmonary artery confluence is so roomy, I wanted to have a flat surface completely sitting across. You see, this is a banded tight.
Would you attempt to close the valve in this patient instead of the banded area?
I don't think the valve is a stable anchor. So I think there's a number of ways of going about this. One is you could just put it in the cover. If you're not worried about the valve tissue, you could just put it in the covered stent. And we didn't see the pulmonary arteries that well. The other thing you could do is, if you wanted to get rid of the valve leaflets, is make a bow tie stent. So you put the bow tie stent in, get rid of the valve leaflets, and then put the device in the bow tie.
I think it's gone in.
What would you do in this case?
I'm not sure I would approach it this way. I would get rid of the valve leaflet. So if the surgeon hadn't got rid of the valve leaflet, then maybe I just asked him to get rid of the valve leaflets and disconnect the MPA. If I wanted to do
It's in the sheet.
transcatheter, I would put a
Sheet,
bow tie stent in, create my own anchor,
Wait, take
and then
another
get rid of the valve leaflets, and then
The
close off
sheet is
the
not-
bow tie.
Okay. So, okay. Thanks,
No,
Alpana.
no.
So, Shiva, what are you up to now?
Yeah, we are actually trying to push this.
We'll take a
Sometimes, these sheets,
Yeah.
sometimes, these sheets from Medtronics and Cordis, they don't work as well. They get compressed by that valve.
Yeah.
So the best sheet is a Cook sheet. If you have a short Cook sheet,
taken the sheet.
Seven French, another
Seven
sheet.
French.
open-
withstand the, or if you don't have Cook, try Terumo 7F if you have. But our experience is that
This is
with,
this is a
Cordis
Terumo
and
7F.
Medtronic sheets, they
Another?
tend to get
This is
compressed
set-
against the hemostatic
So we'll
valve,
take it out. And
and then pushing becomes difficult.
take it out.
That won't. It will be too small.
You don't have another one? Just take
Okay.
it. Take that.
Okay. No. Show this. Let me see whether.
No, we'll take this one. Yeah.
Also, Shiva, since you put the intracardiac echo, you didn't show us any images.
Okay.
What did you
Can
see with eyes?
No. Show the echo. Show the echo big. Echo big. So this is the main the pulmonary artery valve, and what is seen on the left upper quadrant is the banded area. So what I will do is when I am coming out,
take the
I will also
device.
pull out and show you more images. Yeah.
Hanan, why do you think that if you put the device, muscular VSD device across the valve, it will be unstable if you oversize it?
Oh, I don't think it would
Off
be.
color.
it
Off
could
color.
be.
Off color.
That's,
Off
that's
color.
the only
Go
point.
live.
And then if you have some
increase the gain.
instability, then you can have problems with hemolysis and all these different types of things. I think you want to get perfect closure. So just putting in a stent and making a waste on the stent and then closing it there.
Fluorostore?
It's a little bit of work, but I think you get a perfect result, and you're controlling all the sides of everything, and you can tailor make it. There's a large difference, a large length between the
Pressures.
narrowing in the RV and the valve leaflet. So
Can you
could
go to
easily
that
see
elevocranial projection?
Okay.
The same
I'll come
elevocranial
back to
projection?
you.
Elevocranial projection. We are still, you see the hemodynamics also. Show the hemodynamics. Take away our camera. Take the camera out. Show the intracardiac echo. No camera. Because show the intracardiac echo. Correct. So right now we are in the ventricle, and I am slowly withdrawing.
It's gone.
So now I am slightly pulling out my ICE catheter. Oh, it came out. So we have to re-enter. Come back to AP.
I mean, I'm hopefully you'll be able to do that. If I were to approach it, I would have gone from the jugular vein actually. In this, usually when I close these, I go from the IJ. I think it's better, but I'm hopeful that I'm
RC.
sure you'll be able to do it from below as well.
Yeah. So we will.
Yeah, Beza.
I
Mr. Wire.
agree with my friend.
Mr. Wire.
Shiva, it's Behzad from Iran.
Hello.
I have a comment.
Yeah.
Sometimes, because of the very large main PA and also very large pulmonary valve, it's very difficult to close the valve. So you have to go beneath the valve in the muscular part and to find something, for example, an orifice to close it. And because of that, you may have hemolysis and so on. So I prefer, if it was my case, I prefer to have a stent between LPA and RPA
It's
and
curving in
using
the
a covered stent to close all the road here. Sometimes it's much more better and perfect results.
Okay, that's a good thought about putting a very long stent as a channel and completely occluding, and then all the areas below that will be all.
Yeah, absolutely, absolutely.
Z, I have an original idea if you want. You could put a melody valve in the wrong way round.
Yeah.
It's very expensive, but it'd be nice.
It's hitting in that muscle.
We're
And
thinking a more and more expensive solution.
No kidding. Yeah, I like Shiva's idea of he's using a simplified device and
pull through. Will you
trying to
sit
finish it. This case. Any other suggestions or comments?
I think we can come out for this.
Would
It's sitting
you
on the
go through the
infundibulum
IJ
muscle.
in this particular case?
And because of the cable, I think going from the IVC in this case would be a little difficult, because it will pull back the device all the time, and IJ would be a straight shot.
You mean IJV would have been the automatic choice to do? But I've already done it from the
But the angle was such that I don't disagree with Shiva trying from below because the angle is pretty wide. It's not like a very acute angle that you have a higher chance. So I think he'll be able to do it.
Shiva, we have another 5 to 6 minutes to go.
Teji, what would you do in this situation? Would you put a long stent, cover stent? Would you do these nifty things that Al Hanan was suggesting? Or do you simply use this device and flow?
Yeah, I use this kind of a
Just
device
department.
like a plug.
Can you get in the picture where we saw the waist,
The teleocranial.
which is contrast?
Shiva, can you do an angiogram
Yes.
through the side arm?
Yeah.
Or no?
Yeah.
Is it too
We
tight?
can. No. We can do that. Now, previously I was trying to come out without any. Okay. Now get back that view. Eleocranial, steep eleocranial.
This is sir.
Yeah. Srija, just control the sheath. Okay. So I have some more space to come. I think the clipped areas are our point where we have to stop the device.
Now we are
Okay.
at the valve level.
So I am coming closer to the. Hold it there. It's going deeper.
Come back more.
Still a little bit deep, eh?
Yeah, I think so.
Maybe do another injection and see now. Right.
Okay.
All right.
Okay. Hold.
I think he nailed it, but let's see with injection.
Yeah. I'm going to do one now. Okay, that is the left pulmonary artery. Come back to AP view. Or reduce the reduce the LAO. I am going to come out with the sheath a little bit. Yeah. Okay. Come down. Center the picture. Okay. So before some sort of the cable tension is offered, I am going to release the device. See, one of the reasons why we wanted a 3 French cable was to avoid the cable tension, but unfortunately the 3 French did not have the strength, the pushability was poor. So right now I am going to make a final angiography. My cable was actually pulling out it like a whiplash sort of.
Right. So
Okay. So right now let me see what is my pressure in the Fontan circuit. Can you show me the Fontan circuit pressure? Come to AP view. I will flush out the.
Dies.
How much of contrast we have given so far? Not too much, right?
Not too much. You know, we have enough.
What is the saturation right now?
Al-Fanan, what do you think?
Can we replay the angio?
Yeah.
Did you hear that, Shiva?
I will-
Al-Fanan wants you to repeat an angio.
No, replay the angio.
I will do okay. So show the previous angio. I will do a proper pigtail angio.
The question is, because the question is, are you encroaching on the left pulmonary artery, and you're sitting out, and therefore you'd have to put in a bare stent anyway, just to maintain.
No. You see that it's nice and clear.
That's why I always think it's.
Freeze it. Freeze it.
No, it's not. It's not.
I don't think it is.
No,
I think you're encroaching on the left pulmonary artery.
Yeah.
So either show me that you're not, but it's the retention disc is sitting up there, and that's why I like creating proper anchors where I know exactly where they are, and then I get rid of all my problems.
No, Elkanan, it's nicely placed. I'll show you.
What do you think?
I just want to see it tomorrow. Because,
We'll ask Shiva. He'll be here tomorrow.
yeah.
Go ahead, sir. Go ahead. Push the button.
Okay, now you show a projection where.
I'm concerned about the disc sitting into the left pulmonary artery.
Okay.
And I think I'm
Go
just
LAO.
questioning the choice of device. We have done this kind of cases
Okay.
with ductal device, the
go
ADO,
fully
where
cranial.
you would put a hat into the
Completely cranial.
proximal to the PA band, and the rest of the device
Okay.
can go beyond, protecting the flow. So you won't have a disc sitting into the left pulmonary artery.
Okay, now ready to inject?
Okay. Any other comments?
It's not sitting across the LP. I will show you the picture.
Angio will yeah,
Run.
yeah. Okay.
So this is the complete. It's sitting on the face. It's actually it's nicely positioned. It's very well positioned. Now I'm going to pull it back proximally. What sort of view shall we take? Give a Sendilraj, can you turn your face towards the right side? Yeah, perfect. So can you reduce the LAO?
Shiva, we need to go to China.
Bharat, 2 minutes. Just this one picture.
Shiva, couple of things. Tell us what their Fontan pressures are now.
Yeah, I'll give you
And
20. It's 20. 20.
So we can move on to China.
It's 20 right now.
So fenestration closure is out of the question.
Can
right?
you see that now picture? It is not encroaching on anything. It's just sitting on the floor of the.
I agree with you.
It's sitting.
It may be sitting in the LPA, but I don't think it's going to cause any gradient across it.
Yeah.
Shiva.
Yeah.
So closure of fenestration is out of the question, right?
Pressure in the LPA.
Okay. All right. I think this was really, really good. We got to move on to China.
Let me also
Okay.
tell.
And we'll have safe travels to
Yeah. See the
travels to Germany, and we'll see you tomorrow.
Okay. Okay. Fine.
All right. Take care, man. Bye bye.